friends. I actually call her my sister now. We've worked together for about 8 years. Both here, she's on our board of advisory board, our management board, and she's also traveled with me several times to both India and Uganda. I have a tremendous amount of respect for the work that she does, and I'm really honored that she's here, and happy to introduce Emily Haddad, and she's going to be speaking about integrating psychosocial support for patients and their families.
Hi everybody. It's been a great day so far, and I'm really glad to meet you all today and have everybody here in person. Finally, it was a long time coming. So we've heard a lot of people talk today about mental health, and so I want to talk about what that is and how we can address those needs for the kids with extrophy and adults with extrophy and their families. I'm a licensed clinical social worker, so that means I'm a licensed therapist as well. I'm currently living in Baltimore. I'm pursuing my master's in public health with a focus in bioethics, but have worked as a clinical social worker in the Department of Urology for about 13 years. I've also, I've also attended Youth Rally as a counselor and want to talk more about that great opportunity for the kids, as April spoke about before. Was working. Let's try this one. Okay. So my medical colleagues have shared a lot about the definitions of extrophy epispadias complex and cloacal extrophy. So I will speak about the psychosocial implications such as urinary incontinence, sexual health concerns, and how concerns of your kidney health and chronic pain can affect your mental wellness. Certainly we need to talk about medical trauma, self-image, depression, anxiety, and these challenges that these pose to our educational pursuits, our careers, our intimacy, and in some cultures, our marriageability. Also, I want to make sure that we mention the specific implications for cloacal extrophy, which include fecal incontinence, and as Dr. Krieger mentioned, also spinal abnormalities, which affect our ambulation, and these individuals may have more chronic pain. And obviously, with extrophy and cloacal extrophy, we have complex medical regimens and lifelong care that's needed. We didn't talk today about the history of XY males, and I won't speak too much about that today, but we have Dr. Reiner here, who's been a pioneer in advocating and supporting these individuals, and now these individuals are raised male. So when we talk about multidisciplinary care for bladder extrophy, we're talking about, of course, our urologists, our gynecologists, our nurses, our advanced practice nurses. And I also want to include, for some individuals, I just moved back to the Northeast from Texas, spiritual care is really, really important for a lot of families and individuals to cope with their child's diagnosis. When I speak about psychosocial partners, I'm speaking about a whole host of individuals that I'll talk about in the next slide. The goals of this multidisciplinary team are, of course, primarily to improve overall health outcomes. But what I think a lot of my colleagues today have spoken on is we really want to reduce shame and stigma and improve overall health outcomes. And as Pam and the ABC always mention in their mission is so that everyone with extrophy can realize their greatest life purpose and potential. I myself do not have bladder extrophy. I love a lot of people who do. And I've seen people thrive. I've seen people, the birth of a child with extrophy greatly impact the family in a positive way. So I feel very hopeful that with proper interventions and proper supports that people with extrophy can do very well. The picture here is Pam and Janet, who started our Uganda initiative, and some of our great colleagues, a social worker, our late urologist, Dr. Martin Satuma, and a couple of our families that we care for there. Okay, so psychosocial partners. So we've spoken a lot today about psychology, psychosocial needs. There's lots of people in your community who can support you in that way that aren't psychologists necessarily, but may be licensed counselors, social workers, of course, chaplains. When I talk about community health partners, that might be somebody within your school system who helps advocate for your child's 504 plan or IEP. Certainly psychologists, psychiatrists like Dr. Bill Reiner. Our nurses are trained in psychosocial skills as well. And I think the medical doctors that have spoken today have highlighted their great deep empathy for their patients and their hypersensitivity to their particular patient's cultural background and prioritizing patient-centered care. I do think it's really important for those parents in the room to really focus on including a school-based counselor in their child's care and the school nurse, of course. Unfortunately, there's times when you might need to also identify and include a patient advocate, whether that's in the hospital system that you're in or within the school system. And parent peer support, I have found, is one of the most pivotal, changing, and most helpful interventions that I can facilitate for the patients that I've served. So for instance, I had an email from a family recently that was telling me that their closure had occurred a year ago, and they were just sort of thinking back on what that year, how it played out for them. And I said, what was the most helpful intervention that your medical team provided to you? And they said, connecting me to a parent of an adult who was thriving and doing well, because that gave me hope for my child. And I think we've heard from some great adults already today, like Steve, and we're going to hear from some more later that can really inspire your child and keep your family in a hopeful state. When I say support group representatives, there's sometimes local support groups. There's people from Youth Rally who can talk to your children throughout the entire year. And I think for adults, that's really helpful as well. Camp counselors. So I'm going to talk more about camp. You're going to keep hearing me say camp. I really am a huge proponent of it and found it's been really helpful to my patients. So as I said, I'm a social worker, and the global definition of the social work profession essentially speaks about social change, social justice. But one of the things I really want to highlight here in the social work code of ethics, we talk about promoting the right to self-determination, the right to participation, and treating the whole person. And when we speak about that, we're speaking about the person's integrity. So we talked a lot today about how a treatment plan for one child is going to be different than a treatment plan for the next child. We want to treat the whole child, right? We want to treat them within their community, within their culture. And that's what makes bladder exstrophy a bit tricky, right? Because what's right for one kid is necessarily right for the next. So when we talk about psychosocial needs or psychological interventions, let's first talk about the challenges for the extrovert community. Like one of my former colleagues spoke about before, we know from a lot of the research what the challenges are. The next phase is, okay, now what do we do to help the children manage those challenges and the adults? So when we talk about trauma, the definition of trauma essentially is lasting emotional response from distressing experiences, right? So stress is normal. We need stress. If I didn't have stress, I'd probably fall asleep right now because I didn't sleep much last night. But the stress is keeping me awake. It's when the stress becomes too much and too heavy and unmanageable that our body has physical symptoms and we have other emotional symptoms like anxiety or depression. But it's normal to have some response, whether you have a prenatal diagnosis or a diagnosis at birth, of anxiety, fear, shock, grief, despair, confusion. I think that we've evolved somewhat in our culture in the United States to be able to name emotions. I know that my grandmother did not do so, and she was very tough, and I'm proud of her for being that way. But it's really helpful if we help our children, and as adults, we help ourselves name the feeling that we're having so that we can actually address it. The challenges of not naming them certainly can lead to disruption of the parent-child bonding and the integration into the family. A lot of folks have talked today about how delaying the bladder closure has really mitigated this challenge to this infant-parent bonding. And I've noticed that in my 13 years that now delaying, I've seen a lot of better outcomes in terms of the parents being ready for the closure and sort of adjusting to the diagnosis. Better for the siblings as well, because the child returns home and they're able to bond with them. Certainly without peer support, we can have isolation and stigma. Pam and I receive a lot of messages from people around the world who don't have a community like this, don't have maybe access to regular internet use, and feel very isolated and a lot of stigma, which can lead to shame and guilt, depression and hopelessness, and unfortunately sometimes suicidality. Sadly as well, the kids that aren't as privileged and don't benefit from access to care and are within a culture where they're seen as a curse, they are sometimes abandoned. The ABC is working very hard to address these needs so that we can address the equity around the world, so that every child with bladder extrophy can reach their potential and be cared for. Certainly we've talked about self-esteem, body image, so I don't need to sort of list that again, but I want to talk about how we can address those things. So when we talk about psychosocial interventions, this is not an exhaustive list, but there's lots of different modalities of how a psychosocial partner can support your child. They might be integrated within your team. There are a few around the country that have an integrated psychologist, social worker, psychiatrist, but often teams don't. So they might utilize somebody within the hospital system, or they might refer you out to a community partner. There's lots of different modalities for counseling. So there's cognitive behavioral therapy, there's acceptance commitment therapy, EMDR, DBT. I'm not going to go through what all these acronyms mean. I'm sure the alphabet soup will change at some point. But the purpose of all of these interventions is to be tailored to your specific family's needs, to help that your child and your family adjust, accept that there is some grief and loss so that you can experience the joy. Because as everyone has said, these children are predominantly very, very healthy children. But there is some trauma experience when the child is born, or when you go through surgeries and you didn't feel like you knew what to expect, or you had a bad experience. And so trauma-informed care is essential. We want to focus on parent-child attachment. We know from studies about chronic illness that patients and parents who have somebody with chronic illness are at risk for depression, anxiety, and trouble with attachment. But like I said, there are things to mitigate these challenges. Our gynecologist talked about disclosure support, and I'll speak a little bit more about that later. And then certainly some people do need medication management or some more intensive psychosocial support, like a partial hospitalization or an inpatient stay. But as a social worker, one of our primary focuses is certainly on prevention. And so we would really recommend introducing a psychosocial partner from the very beginning. For some folks, like I said, they might need medication, relaxation. Some people might use prayer. And as we heard from Steve, exercise can be very, very beneficial, not only to our mood, but to our self-esteem and our body image. Peer support and mentorship. Pam mentioned that we're going to be creating, with the help of Thomas Vincent and Kim, a patient advisory board, and we're hoping to make sure that we're really prioritizing peer support. So that's matching maybe a new parent with some parents of older kids, children with children of their age, or children with adults that can mentor them. Certainly having access to resources like the ABC and local supports can be very beneficial. During COVID, when we were sort of hankering down and not able to see each other, Pam and I worked with our friend Catherine Brem, who had created that children's book, Boo Boo on Your Bladder, and now it's revised to You and Your Special Bladder. And that's a nice book to be able to share with your children, their siblings, and their schools. School meetings and advocacy. On our advisory board, we have Diane Price, who's a retired social worker from Boston Children's, and she is an expert on helping patients and families learn how to advocate for themselves within the school setting. And like Pam said, we have that bathroom toolbox online now. I don't think we can stress enough that creating a a healthy and safe environment within the school can really make huge changes to these children. We don't know why, but children with bladder exstrophy tend to be much more successful in their careers and in their education, and it's not their IQs. So clearly they are resilient, they are creative, they are innovative, and they are determined. So other examples of psychosocial interventions. Here we have one of our new board members, Carolyn Fazzini. She's a nurse at CHOP in Philadelphia. She has attended the India workshop with us, and she's holding a doll that has external fixators because it just had its bladder closure. It also has an epidural and it has all its catheters. And we use this doll preoperatively to teach the new parents what to expect when their child comes out of surgery. This can be very shocking, obviously, to parents. It's more shocking if there's a language barrier. It's more shocking if you're alone and you don't have community or family support. But being able to see these devices on a doll previous to seeing them on your child can be somewhat helpful. And this is what we call exposure therapy. So oftentimes when we're anxious, we avoid. When we avoid, we become more anxious. So the treatment for that, the prescription, is to face our anxiety and find strategies to be able to cope with it before it becomes unmanageable. We talked about CBT, or cognitive behavioral therapy, psychologists, social workers, therapists that you meet in your community. This is one of the most general modalities that people use. And this is really changing our thoughts so we can change our behaviors, right? So sometimes we have to name that negative belief. Oh, because I have bladder exstrophy, I'm not gonna make any friends when I start school. And we change that to, I have bladder exstrophy. That might make some things challenging, but in fact, as I learned at the bladder exstrophy conference, I have major superpowers because I have bladder exstrophy. I'm incredibly empathetic, I'm sensitive, and I learned how to be very funny as well, because sometimes things are hard and I need some humor. We talked about acceptance and commitment therapy. So again, when you're going in for a surgery, and this doesn't change from when you're a child or an adult, you need to prepare yourself, right? So you might identify what those fears are, what those triggers are, and come up with solutions. So that might be silly putty in your hand. It might be what's called tapping to help sort of regulate your heartbeat. It might be a friend that's on speed dial. So EMDR, I wanted to speak just briefly about. A lot of people who have chronic illness, a lot of people who have had many surgeries, like many people in the room have, do have a trauma history, and sometimes that gets triggered when we least expect it, right? We go in for a general exam once a year, and suddenly we feel like we're hyperventilating, we don't know why. That's your body responding, your body trying to keep you safe. Your body wants to heal, it wants to keep you safe, and that's how it's trying to do it in that moment. EMDR is a way to identify traumatic events that have created a highway in your brain that's no longer helpful. And working with a counselor who is trained in this, you can reorganize this trauma, sort of resolve some of this distress, and reorganize it in your brain. It doesn't mean it's going to go away completely, but it will reduce panic attacks, it will reduce anxiety symptoms, and it's much more efficient than other counseling. So if you don't want to be in counseling, once a week for 6 months, maybe 8 sessions with a very trained EMDR specialist would be very helpful. Motivational interviewing. And so we talked a lot about the importance of instilling hope when we have fear, right? So one of the most important things I think that we can share with families when their child is born with bladder exstrophy is you did not cause this, you cannot cure it, but we believe and have hope that you can care for this. And we have hope for your child. One of the other things, in addition to that, that I think is important to share with new parents, and I think is important for a person with bladder exstrophy to realize, is that this child will change you. They will help you grow. They will help you learn things as a parent that you may have not learned, right? Their challenges will make you dig deep, and that gives the parent hope that, okay, there's no pity here. Actually, I don't have to pity my child. I'm inspired by my child. So camp. So we have Youth Rally in the United States. We have Ostomy Canada Youth Camp in Canada. There's Best Camp Out. I think we talked about another one earlier. The words that got cut out here say community and independence. So like April talked about, it's really important for kids to feel like they can advocate for themselves and see their future. So when they can stay at a college campus, they can see, okay, I can live independently and I can do the things that my peers and my siblings are doing. Somebody recently spoke about disclosure. I actually learned from a parent that they started disclosing to their child when they were 1 day old, when they were an infant. So when they were changing their child's diaper, they started practicing using all that anatomical language, saying bladder exstrophy, talking about what their fears are and their hopes are. And it actually let the parent process things in a way, so when the child knew what they were saying, they were presenting a hopeful narrative, right? It wasn't a fearful narrative. It wasn't a tragic narrative. It was, yes, this is hard, and yes, I have hope that we can manage this. So we know from research studies and we know from our anecdotal experiences the benefits of these psychosocial interventions. So we know that when we provide psychosocial care, we have better medical outcomes and psychosocial outcomes. So we have better compliance, we have enhanced health literacy, patients and families feel like they can advocate for themselves, their partners, and their care. They have access to resources, as Amber spoke about. We know that by providing preoperative support, that it reduces anxiety and we have better outcomes post-operatively. We know that when we ensure peer support opportunities, that families do better as well. Our current Surgeon General, Dr. Vivek Murthy, is speaking a lot about in his current podcast that our depression and anxiety epidemic in the United States is actually caused by our loneliness, right? So we all know what loneliness feels like. The medicine and the prescription for loneliness is community. So when you have bladder exstrophy, meeting someone that has bladder exstrophy, right? When you have depression, meeting somebody that has depression. So I have seen firsthand from leading support groups and being a participant in support groups that they can be profoundly helpful and really reduce that feeling of loneliness, which reduces stigma, which reduces anxiety, and increases happiness. So when we identify and address barriers to getting medical care, procuring our education, pursuing the employment that we want or the careers that we want, and pursuing intimacy and social engagement, that also obviously leads to better psychosocial outcomes. And like I spoke about previously, prioritizing the individual's self-determination and integrity is paramount. So we all know that the previous medical model was that it was very hierarchical, right? Our doctors told us what we were going to do and we did it, right? We're in a different phase now. And the partners in this room, the medical doctors that you and nurses that you heard from today want to hear from their patients. We're in a model where patient-centered care and patient participation is really important. So lastly, I just want to talk about finding a therapist in your state. So like I said, a lot of people won't have psychosocial partners integrated in their team, or they might not have access even in their town, but now there's lots of telemedicine options. Firstly, you can certainly ask your specialist, your urologist, or your school counselor, your PCP for a recommendation. Oftentimes, even if I'm not the counselor that's going to be working with a patient, I might offer to speak to the counselor, and I'm sure a lot of your doctors and nurses would be willing to do that as well. If you have insurance, that would be a good avenue to ask them who is contracted with your insurance. Psychology Today, if you're interested in EMDR, EMDRIA is very helpful. And then we know that if we struggle with managing our medical care, we might have some other issues. So the Substance Abuse and Mental Health Services Administration has a lot of resources on their website.